So we have Hope Stevens, who is a 2-month-old female, brought to the clinic by her mother for establishing primary care. She was born at 38 weeks gestation via vaginal birth without any complications, at home and with a midwife. The mother states she is currently breastfeeding about every 4 hours, but she notes that the patient occasionally sweats and will doze off during feeding, in which she will just nudge the baby and she'll continue feeding and finish the process. The mother denies any episodes of the baby turning blue or in distress and states that the baby produces a yellow stool and about 6 wet diapers a day. The mother denies any surgical history, medication use, or known allergies of the patient. However, she notes that the patient did have a previous URI. The mother herself is 44 years old with type 2 diabetes, and the father is 46 with hypertension and obesity. Currently, upon presentation, the vital signs of the patient: she has an elevated heart rate of 175. She has an elevated respiratory rate of 55. Her height is 45.5 centimeters, which is a little underdeveloped for her age, and her weight is also a little under the normal at 8.17 pounds. Most of her ROS, actually all of her ROS, is very, very normal. However, there were some physical exam findings that were concerning. On her HEENT part of the exam, she has upward slanting palpebral fissures and a depressed nasal bridge, which is concurrent phenotypic findings of Down syndrome. Also, respiratory findings like she's tachypnic. Her respirations are mildly labored, and she has retractions with accessory muscle use. And also there is bilateral crackles, like heard scattered throughout the lung fields. Cardiovascular-wise, she is tachycardic, and there's also a holosystolic murmur heard over the left sternal border. So, with everything presenting, my most likely diagnosis would be Down syndrome with ventricular septal defect. Down syndrome can be recognized by the phenotypical findings that I stated, and also her being underweight or under height can be due to decreased caloric intake from overexhaustion, and hence she's been sweating or dozing off while feeding, which are two signs that show that the baby's getting tired while feeding. And also the lack of full growth states that she may not be receiving the necessary caloric intake. And also, the reason for ventricular septal defect is because in patients with Down syndrome, 50% of them have some type of congenital cardiac deformity, and the most common being a septal defect. And the findings that support a ventricular septal defect are prolonged feeding time, sweat while feeding, decreased development, tachypnea, and labored respirations, and also the presence of tachycardia and a holosystolic murmur support the finding or support the diagnosis of a ventricular septal defect. Other alternatives would be another URI, just because she is already had a previous one, and the presence of crackles, which rule up that diagnosis. However, she hasn't presented with fever or rhinorrhea or nasal congestion, so that rules it down. A do not miss would be the tetralogy of Fallot, because that's also associated with Down syndrome, and also the use of accessory muscles and possible alterations in consciousness, if you can describe that as the times that she falls asleep while feeding. But there is no ejection murmur heard in the left intercostal space, and there's no evidence of cyanosis. So my plan would be to admit the patient for a cardiac evaluation and observation, and also for nutritional support, because the child seems to be underdeveloped, and I'd like to consult a pediatric cardiologist and pediatric dietitian. So the admitting diagnosis would be Down syndrome with ventricular septal defect. And my plan would be to talk to the parents about the nutritional support, but the first step would be for diagnostics would be to have the patient have an EKG, a cardiac radiograph, and blood sampling for karyotyping of Down syndrome, and then also an echo. Further treatment is very dependent on what the findings of the echo and the cardio and the chest radiograph, because that will determine the severity, or if there even is a presence of some type of cardiac deformity. However, if there is a cardiac deformity, we could start diuretic therapy for heart failure, such as furosemide. But we also will definitely need to recommend having the mother bring the patient in to get their 2-month immunizations, at least within the next week, to me, if not today. And also to recommend having them get the syncytial virus vaccination, because that is a prophylactic act to kind of like make sure that the baby doesn't develop any more respiratory infections, or it can help against future like respiratory infections. Other special instructions would be to have the patient come in every 2 weeks so that I can assess their growth patterns and making sure that they're getting the necessary calories. And I'd also refer the patient to a pediatric cardiologist for them to reevaluate the patient themselves.